Welcome, everybody. There are a few more people coming, but I thought I'd go ahead and start with the introductions. I don't know if all of you have been to Kinected. I am the owner of Kinected. Elliot Fishbein, he is the owner of Kinected Functional Manual Therapy, the physical therapist in residence here. And tonight also we have Dr. Ben Laitman, MD, PhD from Mount Sinai. He is a chief resident ENT at Mount Sinai and was really at ground zero at the beginning of COVID in Corona, Queens, and he'll talk more about his experience there. And you know, our goals tonight are to look back, see where we were, what that process has looked like for all of us, for me personally, and Pilates, and what we're doing now. And Elliot is going to talk about, you know, also his experience with patients, but also personal experience as well. So you're going to get a full perspective, and hopefully from the beginning to giving you more information about what's happening now as well. And feel free to ask questions. It's an open forum, so please feel free to ask questions.
All right.
And if someone has a question, just repeat it.
Sure. Yeah, no problem.
Thank you.
All right. Hi, everyone. So thanks for having me and a chance to sort of talk about, you know, some of the things that I guess I experienced, and a lot of us in the medical and health-related profession community kind of experienced over the last couple of years. We'll talk a little bit about sort of current thoughts about the COVID pandemics, or where we're at, and then take a little bit of time. I'll share some sort of personal reflections on kind of things we went through early on in the pandemic. So just some objectives, as I just mentioned. We'll discuss some of the basic current knowledge of kind of where we're at, and then really sort of reflect back. So this is sort of, Johns Hopkins has this dashboard that kind of updates daily on where we are globally in the pandemic. So this was, I kind of took a snapshot of this last night. You know, there have been over 600 million, 600, is that more, I don't even know, that's billion? Is that 600 billion? Is that million or billion? I can't, that is a very big number, but whatever it is, it's a lot. Yeah, and then there's over, you know, unfortunately, many deaths. What we're seeing on the positive end is that now we've what's so fascinating about the COVID pandemic is the rapidity at which we were able to develop a vaccine and now get into the arms of people throughout the world. So it's a real triumph in terms of scientific discovery and sort of public health in that perspective. You know, what really, how these vaccines were even developed, and how does COVID kind of even interact with our body. It's all about, when you look at a virus, you have these sort of little protein sort of ends or little markers on the outside surface, and some normal things in our body, some receptors that we use, that our body just naturally uses, binds to these things and recognizes them. These little things you might have heard on the news called spike proteins is one of the major parts that it connects to. And then once it has that binding into the body, it pulls sort of the virus into the cell, and the cell is able to then sort of send the virus is able to send its instructions into the cell and sort of make new proteins and replicate itself throughout the body. And how this is transmitted is mostly as you guys are well aware at this point, mostly in a respiratory fashion. And that's why a lot of the recommendations over the past couple of years have been in a way to control sort of how much respiratory transmission there is. So mostly that's larger droplets that come out when someone really coughs. We've seen it's not so much in speaking, but more in like real sort of projectile coughing, different things like that will allow for these respiratory droplets to go forward. But things like masks, you know, isolation, separation, these sort of respiratory droplets can't really travel a huge amount of distance. Various protective equipment that we use in the medical community besides masks, whether it's eye shields or gloves, good hand hygiene, these are all the things that sort of allow us to protect against sort of the transmission. There's been a lot of talk about aerosolization. Can the virus sort of remain in the air for a period of time, which is sort of separate than just these droplets? There's some evidence that it may, but the extent to which that's really contributed to transmission of the virus it's really not well understood or well known, especially in the sort of later stages of the virus and sort of how it's being transmitted now. To understand a little bit about how our body reacts and how these vaccines work, it goes back to the sort of a little bit of basic understanding, as many of you might be aware, of how the immune system sort of generally behaves. When our body is supposed to see things that are us, the self, and things that are not us, the not self. And when it sees the not self stuff, it gets a little frightened, it gets a little scared, and it kickstarts our immune system to go after it. And the immune system sort of has to figure out, is this a really dangerous not self that I should pay attention to, or maybe I can back off and forget about it. So we have, let's say it's some sort of pathogen, a virus, a bacteria. It will put something into the bloodstream, or it will be a nearby, blood cell will see it. And it could be anything. It could be various proteins, like the spike protein, for example. It'll be sensed by the body. And then we have two different forms of immunity. One is a sort of initial, what we call innate immunity. The body just reacts, just full court press, reacts to whatever it is. And then there's this adaptive immunity, where certain cells are also triggered to develop and remember that pathogen. Okay, and that's kind of how the vaccines sort of work. It sort of fakes out the body and says, we have a pathogen here, we should respond to this. And we develop this adaptive immunity that then remembers it, and then if we see it again, can come back and fight it a lot better. And so we have two sort of flavors of this, one where we have antibodies sort of released, and so you hear a lot about antibody titers and does the vaccine stimulate antibodies to be formed, and that's one form, and the other is actually one we don't talk about so much in relationship to COVID, but it is happening. It's the T-cell immunity, so a separate sort of adaptive immunity. So it's not all about do you mount an antibody response, but do you have a T-cell response as well? So why many of these vaccines may still work, even if they're not mounting these great antibody responses sometimes in some people, is that there's still these T-cell responses as well. And so the different vaccines that are out there, there are a few different flavors that the COVID vaccine comes in. And the really fascinating thing about what the scientific and medical community was able to do in the coronavirus pandemic is it was that we were able to develop a vaccine faster than any vaccines really been able to be developed previously, in part because it's a brand new type of technology. I have a couple slides showing what the older, more tried and true ways of making vaccines and what they are, but this is what's called an mRNA vaccine. And what that is that in a lab, they had a COVID virus. They were able to create the protein instructions, if you will, in a lab, and then that's what's actually being injected into arms in the vaccine. And then our cells use those instructions to just make the protein, not the virus, and then our body responds to that protein that's on the COVID virus in the community. And that's a little bit different than the old ways where you can inject literally the virus, okay? Usually we kill it, some sort of deactivated or killed virus, or the proteins of that virus, but that takes time. It's so much easier. We, in labs, can make these mRNAs, make these instructions very simply and very fast, and you can modify them very quickly. So it's a new technology. It's why we're able to sort of kind of roll with the punches a little bit in the COVID pandemic, and maybe something that we see in other vaccines, flu and whatnot, going forward as well. In terms of where we are in terms of treatment, a lot of it has stayed the same, okay? We wear masks, hand hygiene, social distancing, isolation. There have been breakthroughs, though. We've had now antiviral treatments. One of the biggest ones that's given out is Paxlovid, where if you've had sort of an early infection, these antivirals have been shown to decrease the severity and the time course of these. And then in the hospitals, the thought process has changed dramatically from where we started. Obviously, basic therapy is giving oxygen, but steroids, different agents that can modify our immune responses, different antivirals, even giving the antibodies themselves to directly attack the virus. In my world, I'm an ear, nose, and throat doc. We've seen that there have been short and long-term complications. I couldn't get through with this without mentioning these because I think they're interesting. There's a lot. COVID affects more than just the lungs. We know it is a respiratory virus, but it affects everything. What's really interesting is that it seems to, especially early on in the pandemic, we saw a lot of people didn't even notice they had COVID because of a loss of taste or smell. And so what it's actually going into is probably infecting in some ways the nerves or causing some sort of inflammatory response in the nerves up high in our nose that are able to smell. And what we've seen actually in the ENT world is that we're able to treat this a little bit in ways that we actually normally treat what we call post-viral or upper respiratory infection anosmia. We give a smell retraining therapy where you sniff essentially like eucalyptus and rose and lemon and whatnot like 4 or 5 times a day for a period of time. But we also have seen that certain fatty acids actually might help. So it's a really interesting thing that we're helping a lot of people with nowadays because it's one of the first things we saw in the pandemic, so we kind of understand a little bit more about it. My specialty is more in the voice, airway, breathing, and so what we're seeing, unfortunately, in a lot of folks that had long-term intubations, the tubes down the throat or the tracheostomy tubes in the neck, is that they're getting long-term scarring in their windpipes and requiring various either surgeries or various procedures to help dilate those, and it's something we're kind of seeing as a sequelae now, a year plus after sort of the peaks of the pandemic is something that we're seeing in a lot of patients, unfortunately. So that's kind of where we are. I'd like to take a few just to kind of go back and sort of where we came from. So the beginning of the pandemic, February, March, April 2020, I was a junior resident, and at Mount Sinai we work over at Elmhurst Hospital in Queens, which is one of the most diverse neighborhoods in New York City, if not the world. I mean, if you want a food tour of the world, that's where you should go. I mean, really is, on a side note, tremendous place to go eating, but really wonderful diversity of community, and they all come to this hospital. And for whatever reason, because maybe of just the way sort of public city hospitals work, a lot of folks were filtered to Elmhurst early on in the pandemic. And it ended up in sort of the dam broke, where the hospital system, New York obviously was one of the first hit, but that hospital in itself was really hit hard and was having a rough time managing the influx of patients. There were so many building up in the emergency departments, in the floors, the ICU, the intensive care units, that we started sort of, and because we couldn't practice our normal jobs, the ENTs, ophthalmologists, everybody was just, they couldn't do their normal jobs anymore. The whole world couldn't. But in medicine, we weren't doing the benign anymore. We weren't taking out people's tonsils. We weren't, looking at earwax. We weren't doing any of the normal stuff. And we were sidelined, and we were asking ourselves, what are we doing? As we see our friends hurting and needing help. And so many of us went to volunteer in various sort of new wards that were opened up just for COVID in the hospital systems. And in Elmhurst specifically, we started opening up makeshift ICUs, and intensive care units. So there's normally 1 or 2 in a hospital. We would turn a room literally probably like this into an ICU with patients with vents, and they would have I'm sure you've all experienced rooms now where they suck the air out to sort of make a negative pressure space so the COVID virus doesn't go in, doesn't circulate. So we'd have big negative pressure rooms that were like isolation units, and those were our ICUs. So I want to just touch base on this. I will say it's a little bit of a difficult topic sometimes for me to talk about, and maybe for you as well. So I just sort of a little bit of a trigger warning for those that this has been a difficult time the last couple of years. There are some sort of difficult things I'm going to show, but just I would like to kind of sort of express what it really was like for many of us on the front lines early on in the pandemic as a way to maybe be a message for the future. So that's a picture I took the first day I had to wear one of those N95 masks that you hear about on the news. This was on March 15th, 2020. I remember a couple days prior us looking at the news, and they were maybe 15 days prior, and seeing them talk about stuff from China and saying, hey, is this actually going to affect us? We were like, a lot of us didn't think this was really going to be a big thing. And I've worn those masks twice before as a doctor, and they're used to be used only for patients when we had to encounter patients with TB, which is pretty rare nowadays, but that was it. We have to get fitted for these every year, clean shaven face, which I don't have right now, and make sure it really fits, nothing can get in and out other than our breath. And every year I'd be like, why does this matter? I never wear this mask, okay? It doesn't really fit my face. I always just pretend that I can't. They spray a little like taste test. Can you taste it through the mask? I always just say, no, I can't, but sometimes I could, okay? Never thought I'd need it. So I sent this to my wife saying, look, I have to wear this mask. This was about a week later. I'm starting to wear face shields over the masks and getting a little bit sort of nervous. And this was, I think, a couple weeks, and this is not even the worst of it. I'll show you a different one, but basically we would start wearing 3, 4 different layers, gloves on gloves, to start to protect ourselves. This was the beginning. I think this was this is the Elmhurst Emergency Department, which usually is pretty busy, but these units, the one on the left was that's normally like a trauma unit, and the one on the right is normally the unit where people like go for like minor broken bones, cuts, things like that. And I walked in one day and I saw these curtains started being put up, and these were the beginnings of them started making these isolation units. And I would talk to my friends and they were like, I've never intubated, which means puts the tube down the throat, never intubated so many patients in my life. And this was over the course of a couple days. And so you started to see the floodgates opening and getting a little bit nervous about what was to come. And then they started putting up all these signs, various contact precaution this, droplet precaution that, can't enter this room. Everything started to be siloed off. Still no eating or drinking beyond this point was always a thing in the ED, but regardless. Shortly thereafter, things kind of exploded, and like I mentioned, we had to sort of develop our own ICUs, intensive care units, because to help with the overflow. So there was the main ICU in Elmhurst, and then there were 3 extra ones. They were run by the ear, nose, and throat doctors, the oral surgeons, and then one was run by the Navy. So we were just like, all right, whoever, the Navy we kind of understood because they were getting nurses and docs from around the country, and they brought in the Army, they brought in the Navy. It was really overrun. But we have in our profession, have a pretty good understanding of the airway and breathing and sort of respiratory issues. So everyone in our unit were intubated patients, so they were all asleep with the tubes down their throats, and we knew how to manage a large aspect of that. We, however, had to I'm not an intensive care doctor by any means, and I was never really trained as such, and none of my friends were. So we were essentially doing crash courses at night to teach ourselves critical care medicine in order to try to take care of some of the patients that were there. So I play this next video is the next couple are a little tough. So I put the link at this at the end. During this entire time, I wrote a blog about my experiences because I was a few posts just to kind of actually as an outlet. And I reread it last night because I wanted to sort of put myself in the mindset again of what it was like, because it's a couple years now and we're far removed. So like I said, my day-to-day is not this, and we were never trained for this. And things start to build up in the ICUs. Rooms that were normally meant for cuts and bruises were now filled with 30 some odd patients, some on ventilators, some awake but not doing well. And unfortunately, many were dead. What happened at Elmhurst in Queens is that there were so many that were unfortunately dying that we could not keep up with it and get them into sort of the morgues and things like that fast enough. So some of our units were literally housing a live patient next to a recently deceased patient. This is a quick sort of snap video. There's no patient information or anything, but this was sort of literally I had to document what it was like, and you can hear these blaring noises. This was a room that, before we were in ICU, we had a mini unit in a room that had 30 patients. We were taking care of 6 of them. And we were wearing 3 or 4 layers, helmets, masks, gloves on gloves, masks on masks. I was sweating, and then the volume should work on this. Just everything was this loud, alarms. You could not hear, the video might not be playing here for some reason. Well, probably better off. The sound is actually the thing that I wanted to get get in there more than anything else. I can share the videos after. This was me on this is actually a description of the blog on the news. So basically, this blog ended up getting picked up by ABC. So I put this on here mostly because I think I explained myself a little bit better then than I am now, and I record it. You'll hear my then 1-year-old daughter in the background saying "Dad, Dad" about 45 times because I was on the news, and my wife telling her to shush. And I'll touch base on some of the things I said here as well. But maybe this is. Let's see.
They realize their job is far more than saving lives, but become the bridge between families and their loved ones who've often passed before saying their
That's
goodbyes.
actually
Eyewitness News reporter Stefan Kim spoke with one doctor.
This is well outside of our comfort zone.
We were wearing
Really deal with death directly on a day-to-day basis.
He is an ENT resident at Mount Sinai Hospital, but about a month ago, Dr. Laitman walked on the sidelines as his friends got hammered on the front lines. He watched as the pandemic engulfed New York. So he and several colleagues volunteered where their city needed them the most, at a makeshift surge ICU at Elmhurst Hospital in Queens. It was the epicenter of the epicenter.
But I wasn't ready for this.
As he he says it felt like a tidal wave of death hit him in the face, and the pace was unrelenting. He was terrified about bringing him home to his wife and 20-month-old daughter. He was terrified for how his patients' families would have to say goodbye.
Seeing people pass away without loved ones at the bedside is just not right.
Sometimes the video chats he hosted for loved ones would happen after a patient had passed, because sometimes they died too quickly. Imagine having to hold up to a dead patient and watching each child and spouse say their final words while holding each other as they cried, knowing on the other end their loved one was already gone.
It was really difficult. It was hard to see those families say to say their prayers. I'll remember what that looks like. I'll remember what that looks
On their free side, Stefan Kim, Channel 7.
It's a nice juxtaposition, actually, because my daughter's probably what got me through it. But basically, I mean, 2 daughters now, but the second one wasn't born yet. But it's it was a really rough time, in part because we had a lot of folks come to our unit where they were very far gone already. As I mentioned, there were just too many. They were sitting in the emergency room trying to be taken care of, and they came up to us and honestly would shortly die thereafter. We were sort of like a little limbo space. We were trying to help them move along, get to get healthier. We had a couple people that maybe did, but many of the people that we saw in our unit were kind of too far gone. And it was hard because I felt as if, as I mentioned, I'm not trained for this. Was I hurting people? Were we hurting people? But it was sort of a moment of, if we weren't there, no one was going to do this. They were just going to kind of sit around, and because of the overflows. And as I kind of mentioned here, there were families weren't allowed. I mean, this was an incredibly unrealistic, untenable situation where imagine having a loved one not be able to be with their family member, and instead having to have some random person hold a phone up to them to say their goodbyes. And I've had to do that. I had one point where I called a family and I spoke to them and I said, hey, your family member is going to probably pass away shortly. I'd let you know if you want to say something. And I went back into the room, and unfortunately they had passed in the time period I was making that phone call. And I spoke to the family, and they still wanted me to put the phone to them. And I stood for 20 minutes holding a phone to someone who had just passed away, so they can say their goodbyes. And I didn't speak the language they were saying, and it was very difficult. And it took me and a lot of us in the community, a long time to recover, because we all felt out of our depth. We all felt like we were sort of drowning. So it's being in the world now. I have photos of the first day I got my vaccine. Probably many of us do. Like that was a very joyous moment for many of us. We've come a very long way from the beginnings, where these, floodgates of people were there. We understand things better. We can treat people better. We're in a much more positive world now, but the beginning was tough, and so it's sort of like a warning. This is just a picture of me. We wear these masks on our faces all day, and we all wear them now, but these things were so glued to our faces that they were making indents and impressions on us. And we were all getting these like incredible like ulcers on our noses, like where they were like almost burned through, because we were wearing these almost 24 hours a day. We would have like isolation rooms where we had no idea about how this was even spread. We were all wiping our boxes still with with bleach and stuff like that. We had no idea. So we would go from one room, I would scrub myself, I would change to get into like another pair of clothes that I'd go home with, and then I would, strip before I even got right into the door. It was absolutely nuts. So I think the last things I'll say is there were some positive things in all of this, in that I think it's trained it's reminded the medical community why we're here. I think we often lose sight of that, and that we're here to help people. And this was a time where the entire medical community, nurses, doctors, other health-related professions, stepped up and really helped when they were needed. And that's why we're all here. And we were kind of given a new lesson in empathy, a new lesson in how we can really be there for people. If I can't be there for someone really medically, if I don't know how to help, I could be there for them, for their families. I could be the guy that holds a phone and allows for that connection to be there. We had a wonderful group and it reminded me of the respect I have for some of my colleagues, the people that, again, stepped up, and we were all afraid. We didn't know if we were going to bring this home to our families, our friends. We didn't really know anything about it. And it was a lot more sort of death and morbidity than we ever thought we were going to be exposed to in our specific profession. But it was a wonderful thing to see the people around me kind of come to the aid of the community. So some takeaways: I think we've really have come a tremendous long way from the beginning days. And I could talk about this for a very, very long time. There's a lot of different stories. This is defining our generation. This is defining the way my kids are growing up, obviously. But we're seeing the world return to normal, right? I mean, we're not all wearing masks. We're, different things like that. It's a different world. I think, though, that unfortunately history shows us that our memories are pretty short. And so hopefully we don't make some of the same mistakes that led for this thing to sometimes get out of control. And these types of stories, I hope, are a way to like remind us to say like, hey, these things are still going to be in our world, different almost pandemics that come to fruition. These might be things we see again. And we have to be careful, or we're going to be right back to these horror stories. And so it's not to scare you, but to sort of remind you of sort of staying vigilant and continuing to learn and help as we kind of move forward. But I think on a positive note, things are definitely sort of back. I could say in the medical world, we're pretty much back to normal. Like things are kind of running like they kind of were in the past. So I'm pretty happy about that. And my kids are growing up in a good environment, back to school, and everyone's good. So. If you are interested at all, that's the link to the blog. It sort of describes some of the stories if you want to read it at your own time. That's basically it. I'm happy to answer any questions, share more stories at some point, but that's what I wanted to say.
Quick question.
Yeah.
So in terms of like your current treatments of like long COVID and how they relate to ENT.
Yeah.
What is just a rough? What are some of the typical cases that you see?
So in the ear, nose, and throat world, a lot of them, from the benign, we get a lot of like people coming in for chronic cough, even like voice changes or reflux, because this virus seems to not only affect the respiratory system, but maybe the nervous system in some way, or caused a post-inflammatory change in like how our nerves sense things. We have a lot of people coming in with cough and voice changes, reflux. The anosmia is still around. We're still seeing those types of patients and offer. the lack of the smell, which leads to not only a lack of smell, but sometimes it's interpreted as a change in taste because the way taste and smell are so tightly integrated together. And we're offering those patients some of these basic treatments, but there are also various sort of trying to design new clinical trials and treatments we can offer for that. We have people with these long-term breathing issues, and some of them are these scarred lesions of our windpipes and our vocal cords. But some are less, we don't understand. They maybe are starting to get like a they almost like develop asthma or other lung problems from just having these infections. It's
like a reactive airway.
Yeah, exactly. This may have pushed them over the edge. You know, a lot of these reactive airway diseases are a combination of our genes and our environment, and this may have been sort of the environmental factor that's pushed some people over the edge on that regard. At least in the ENT world, we're not seeing, you know, chronic sinus infections are kind of coming up in some people. There were some early case reports that people were getting some hearing loss, like sudden hearing loss. It's hard to know how well those were substantiated. We do know that sudden hearing loss can occur after some viruses. Usually it's related to like the herpes virus, which is a pretty, you know, widespread thing in the world. But it's possible, and so we might be seeing some of those related to COVID. It's, you know, quite possible. Yeah.
Is there any other symptoms that you would like to mention that if people notice that have had COVID, that
Yeah.
they should go see their physician, or even specifically in ENT?
Yeah, I think that if, you know, COVID in general, I think if you've had, you know, well after, you know, long COVID symptoms of persistent fatigue, trouble breathing, those are sort of the biggest things. You know, obviously you should see, you know, your physicians for. I think within the ENT world, there are things we can do for those loss of smells, loss of tastes, chronic coughs, voice changes, and definitely if you're having really difficulty breathing, it may end up being that you kind of get funneled to us eventually, depending on where the level of the difficulty breathing may be.
Do you know anything about the fatigue aspect of long COVID?
You know, it's a lot of these things are still unclear. There's a big sort of number of studies ongoing at Sinai at Mount Sinai Hospital uptown to sort of understand long COVID. It may be a combination of things. We know that COVID not only affects the respiratory system, the nervous system, it has sort of this hyper-clotting aspect to it where the various blood vessels might get clotted off on a large or even a small basis, and that degree of, you know, vascular sort of clotting maybe has some effect on some organs. Usually it's, you know, whether it's muscles, lungs, things like that. Those things are still kind of being learned. It's difficult because so many of the long COVID symptoms are kind of vaguer in nature. It's harder to understand, for sure. It's not a persistence of the virus. It's more of a long-term effect of, you know, that virus. And people with severe infections will tend to have a higher rate of these long COVID sort of responses, or if they have sort of underlying medical conditions where they're already maybe sick from other things, they may be sort of tipped over the edge and have worsening of those things. Usually the very benign asymptomatic things are not leading to long COVID. There have been reports of that, but it's more often the sort of more severe infections of hospitalized patients and folks that have had to be in the intensive care units, and even the sequelae of being in an intensive care unit, various, you know, IV, you know, intravenous lines you have to have, or tubes or medicines you get. They all have the lying in bed for a long period of time. These all have very long-term effects on the body, leading to muscle atrophy and long-term fatigue and things that take time to improve upon.
All right, thank you.
Yeah.
Sir. I'm going to pull up the presentation here. let's see, get this to the beginning and slideshow. Let's see, that's working. All right, so hi everybody. My name's Elliot Fishbein. I own KFMT, the physical therapy practice here. And so I'm going to be discussing more long COVID. And so this is, this was an interesting presentation for me to put together and a tough presentation for various reasons. One, at this point I've worked with a fair amount of people who've had long COVID symptoms. I have not worked with anybody. It was interesting hearing Dr. Laitman talk about people who are having scarring in their airway because I have not worked with anybody who's been intubated. And so that's not something I've seen, but I can imagine that would be a huge problem. But also, this was a tricky presentation because, like he discussed, there's not a lot of clarity with what's going on with long COVID. And also, I have long COVID. And so either the day before or after he was wearing that mask in the picture, I had my first COVID symptoms. And I am fairly certain I had inflammation in my heart. I did not go to the hospital because it was not to the point where it was really bad. I was bedridden for many weeks. I lost about 15 to 20 pounds in the first 1 to 2 weeks. And for a few days, I couldn't sit out of bed for more than a minute or two without needing to go back in. And keep in mind, the week before, I had played full court basketball. And so this is like what COVID did to you. So I have a unique perspective. However, I will try to, and pretty much every symptom I'm going to talk about here, unfortunately, I was fortunate in that I got a really high percentage of all the COVID symptoms. So fantastic. I got to experience all those things. So I will try to give personal experience, but I also don't want to make this about me. More or less what I want this to be is to try to give where the current understanding is and what they're looking at with long COVID, what medical treatments they're looking at, and then also what treatments you can do with exercise, with physical therapy, with manual therapy, and then alternative method. Also talk about different alternative treatments and what they're looking at, because I know certainly I have been helped by many of these things, and I also have had patients who have been helped for many of these things. So I want to make sure that we kind of get to all the different things that people are using. So, long COVID definition. It defines long COVID as a condition among those with a history of probable or confirmed SARS infection, usually 3 months from the onset, that cannot be explained by alternative diagnosis. Sorry, I don't want to read the whole thing. That's too much. The bottom line is it's people who have symptoms at least about 3 months after that shouldn't have it anymore, that can't be explained by any other diagnosis. Now, I will note that there are multiple definitions you'll find. The reason why I note this is this extra presentation was really tough to put together because nobody agrees on virtually anything. So the definition of long COVID, some places will say it's 6 weeks, and that makes some sense in that most viral illnesses, you still might have symptoms for about 6 weeks, and at a certain point that starts to clear up. So you'll read different definitions of what is long COVID. People have different ideas. There are different names. Not everybody calls it the same thing. I'm calling it long COVID in this, but it can be called chronic COVID syndrome, long haul COVID, post-acute COVID, persistent COVID-19, post-COVID-19 manifestations, all kinds of fun things. And it is a syndrome, meaning this is not like, it's not like, you have this and it means something very different sort of to everybody. But it's a cluster of different symptoms that may or may not appear. Because the craziest thing about COVID is it affects everyone in largely different ways. Somebody who may have, some people will have big heart issues with their heart. They may have heart damage. Some people may have lung damage. Some people may have kidney damage. Some people may have none of those things but have symptoms of all of those things. Some people have loss of smell or difficulty breathing. It is a very difficult thing to understand because it is so different for everybody. So you're trying to find what is the common thread that kind of, the medical community is looking for what's the common thread that's causing this so we can kind of stop it before it gets to that. In the ideal universe, vaccine has gone a long way towards doing that. In terms of, and also just noting that while most people who develop long COVID have symptoms, I'll talk about that a bit more in a second, there is a percentage of people who are asymptomatic when they test positive for COVID, but then have long COVID. And that can be a bit maddening because you kind of think like, oh, COVID's nothing. I know when I've had, there's a part of me when I was really in the worst of it, my first 18 months to 2 years, which was, it was that long. And you'd hear people who are like, it's a small cold, you don't have to worry about it. I'm like, I don't know. You got the long end of the stick. I did not. So in terms of the symptoms that you can have, I'll talk a bit about some of these. Brain fog, cognitive deficits, memory difficulties. There are many different things, actually. I've even had people talking about verbal, there's studies that talk about verbal difficulties, difficulties with executive function. Like there's a lot of different ways that can present. I can tell you that in the early stages, I remember, because I run a business and I was communicating with Matt. We were talking about the studio and all this stuff, and I had one day where I had to send like two emails, usually take me like 5 minutes, and I was having an anxiety attack because I could not get it done. And it was a pretty nutty experience. Post-exertional malaise, again, had tons and tons of that. Really, a lot of issues with that, so you'll find that for patients. Fatigue, weakness, shortness of breath, or chronic cough, headache, dizziness, chest pains, heart palpitations, hearing loss, or tinnitus. I should also mention, with heart palpitations, chest pain, some people will go into congestive heart failure. Some people do have heart damage that can cause them to go into heart failure, because everyone's slightly, and also, with people who are having chronic coughs and chest pain, things like that, it's important, we'll talk about it later, it's important to see your doctor because there is a difference between people who have had scarring, meaning the virus created a process where it actually scarred or damaged your lungs or heart, versus those who kind of end up in the more nebulous area of, they look at you and they say, everything's fine, but you're having all these problems, which is a big problem. Obviously changes in taste and smell, depression, anxiety, irritability, GI upset, meaning stomach problems with digestion, joint or muscle pain, sleep disturbance, changes in menstrual cycles, and autonomic dysregulation, or POTS. Again, what that means. So a few things I'll touch on is that for the people with the severe fatigue, this is presenting for many people like chronic fatigue syndrome does. So it's been interesting because a lot of the research that's been done on that is people are like kind of going towards that. And it's also, chronic fatigue syndrome is something in the medical community that is often kind of ascribed to psychological causes, and that there's been a push to get, and I think people who've worked with those patients have always worked to get away from that, but now there's kind of a bigger push of like, no, there's something happening that is triggering this. And again, that's not, to be clear, that's not all doctors, but that has been something that you've heard stories about a lot. In terms of autonomic dysregulation, or POTS, POTS is postural orthostatic tachycardic syndrome, which means that these are people who have similar symptoms to COVID, where their heart races, they're very fatigued, they become short of breath, they start having anxiety, irritability, things like that. And it's what it is, and it's something that happens often in women, smaller women, it's more commonly than men. And it's the sort of thing where it was also something that people would ascribe to anxiety and depression, things like that. And what they've realized is that it's a condition where you kind of have something called orthostasis, where you get upright and your blood does not quite get up to your brain. And so things start dropping and you start getting lightheaded, you get weak, you get fatigued, it can affect your cognition. Your heart starts racing because it's having trouble pumping out blood. And so there's treatments for that we'll talk about that also may be applicable for people with long COVID. In terms of prevalence, again, there's no consensus on how many are affected. There's general estimates, but again, this was actually, this took a lot longer to put together than I expected, simply because there's no centralized source doing the research on this, and so you're finding numbers that are kind of all over the place depending on how they did the study, what they looked at. But I summarized, I actually took out some stuff here, but 10 to 30% of patients who have COVID will experience long COVID symptoms. And Harvard just did a study where they actually just called it, I was reading an article, they just called it 20%. They just averaged it out, and I'm like, okay, that works. But that's still 1 in 5 people who get COVID will develop these symptoms if you average it out. Again, up to 30% of those with severe disease, and people up to 50% of those who are hospitalized. So Dr. Laitman was talking about how, again, with people, you don't realize it at first, and then there's like this fallout from being in the ICU, and that can lead to long-term repercussions. And so if you are hospitalized, particularly if you're intubated or ventilated, you have a much higher incidence of developing long-term symptoms than the general population. Again, the US government estimates anywhere between 7.7 to 23 million. That was in March. I did read something that said the other day, this was in an article in the news, not in a publication. It said up to 28 million, so I will put that out there, but I don't know that that number is 100%. But obviously this was in March, so things are, there's more and more data coming out. There's more than 1 million people out of work because of long COVID as of March of 2022, and it is now considered a disability under the American with Disabilities Act, which is probably a good thing considering 1 million people are out of work because of it. You know, in terms of, you know, one federal estimate in, you know, again, this is where some of the variance comes. It found that in, you know, about 5% of adults in COVID-19 were still experiencing one symptom of long COVID. But that kind of totally conflicted with a study that came out a few weeks ago from University of Glasgow, which showed that of people who've had long COVID symptoms, you know, about 42%, 6 to 18 months afterwards, had only partial resolution, and about 6% had no resolution at all. So again, people who are getting it, about 50%, anyone who's getting it, you know, at about maybe 3 months or so, you know, maybe about 50% are not getting any sort of complete resolution. So some people are working towards resolution, but at least 50% or about 50% are staying towards either partial or no resolution of their symptoms. The other thing that was quite surprising to me, and I just read a sort of meta-analysis that kind of summarized what's going on with children who've had COVID, and it actually said that, you know, 25% of kids who tested positive had long COVID, meaning that 25% of children who were testing positive for COVID were developing long COVID symptoms. Dr. Laitman's making a face, and I don't know. All I know is it was a meta-analysis. I was surprised by that number, but it was saying about 1 in 4. But again, I'm sure that's going to come more not. And they said the most common things they were finding is fatigue, mood issues, and changes in sleep that they were finding with children who've had COVID. You know, in terms of who's going to get it, you know, obviously the more severe your disease was, the more likely you are to get long COVID. If you had underlying health conditions prior to getting COVID, you are more likely to get long COVID. If you're unvaccinated. Now, they're just coming out with the data on vaccination. However, the one thing we know about vaccination is if you are vaccinated, you're much less likely to get severe disease. And if you get severe disease, you're much more likely to get long COVID. Therefore, by extrapolation, you can say long COVID, you're going to be in a better position if you are up to date on your vaccination. And then people who experience multi-system inflammatory syndrome, a lot of kids got that, or not, I shouldn't say a lot, but a small percentage of children were getting that. That's a condition I do not understand very well, but it is a more serious condition that was affecting the pediatric population. The one thing I will also mention, because I found this the other day, which is that the study that just came out of Harvard that did find that people who have a history of anxiety and depression prior to getting COVID had a much higher likely percent of getting long COVID. So if they came into it as one of their past medical history, like underlying health issue, that they actually, I think it was like 46% more likely to get long COVID. That being said, long COVID is not anxiety or depression, I promise you that. You know, so what causes it? You know, right now it's all hypothesis. People are kind of getting their best guess. So some of it is that there's latent either virus or parts of the virus that have become kind of dead and kind of like got stuck in there that are triggering a chronic immune response or inflammatory response. So your body keeps kind of triggering like it's still sick, but you are not sick anymore, and so you keep having these symptoms. You know, overactive immune cells, this is more when you first get it, where like you've had overactive immune cells when you first get COVID that actually causes scarring or damage to parts of your body, or you know, your heart, your lungs, things of that nature. Autoimmunity, meaning that, and this can happen with any viral illness, is that, and you actually will find this, you've probably heard stories about people who are like, oh, I had a really bad response to the vaccine, or I got this and I have I had symptoms I didn't have before, is that any virus can actually trigger an autoimmune response in your body, meaning you can suddenly start kind of having sensitivities to different things that you didn't have before and kind of start feeling some of the symptoms of COVID. And then the other thing is that, you know, when you have COVID, it can affect your gastrointestinal system. And so you can have interruptions in like the bacteria that you're in your intestines. And that is a big part of where you develop your immunity. Actually, your immune response is largely modulated through your gut. And so when you have that, what they call like dysregulation of that, or the bacterial system in there is interrupted, suddenly you actually have like immune responses that you shouldn't have, and it can lead towards things that can cause some of the symptoms that you get with long COVID. Other things that they found recently is that they actually, in a lab, they're trying to understand why it's happening. And there was a lab that created mini brains and infected it with SARS viruses. And what they found is that normally your brain will kind of, your neurons will do these things where they cut off synapses, things you don't need anymore. It's called pruning. And they were finding that actually it was happening way, way more when they infected it with a COVID virus, or with a SARS virus. And so that actually showed that you would not normally get that. So that's one theory as to why people are having memory loss, cognitive difficulties, things of that nature. Also, there's a brain biobank in England that it was already studying brains. So it had people, they were studying their brains. And so it was able to go and look at people, they had a pre of their brains, and look at people, what was the year? It was about 141 days in between, where they had their baseline, and then the patients who did have COVID and the patients who didn't have COVID. And what they found is that in patients who did have COVID, and did have who had tested positive for COVID, they had a decrease in their brain size. And they also had evidence of scarring, interestingly enough, evidence of, not scarring, but what was it? There was markers of tissue damage, yes, in the area that actually was around smell, that process smell in your brain. So that can explain some of what's going on with the people who are having issues with their smell. So in summary, so pretty much you've got, people haven't fully agreed on a name or a definition. How many are affected? We know a lot, but no consensus on that. Again, they're trying to figure out what the cause is, and they're just looking at options right now. So there's no definite treatment for it. And so obviously right now there's a lot of people who are very frustrated and really in despair. And so, as part of the next thing, the question becomes is, what can we do? And so I'm gonna talk through some of things that, I will preface this portion with the fact that, we're all kind of like throwing darts a little bit, because and a lot of people have a lot of really smart people are doing different things, both in terms of exercise, manual medicine, actual, medical treatments, things like that. And there's, what I'm finding is that, the first thing that the NIH says is there is no specific treatment for long COVID. So it's oftentimes trying to understand what the symptoms are the person is having, and then trying to find an optimal treatment regimen that makes sense for their specific issues. Generally speaking, what they say in the literature, and I completely agree with this, is that essentially you need what you'd call a multimodal approach, meaning it's not like you just take a pill and you're better. It's like for each person is trying to find the combination of things that can help them get to their best place. I've seen patients who have had COVID, long COVID symptoms, and I, in some cases, have been able to be helpful. In other cases, not as much. But one thing I can tell you is me alone is mostly not going to do it. There are case studies of different things we'll talk about where there's like, this person did it and they felt great afterwards. But for the most part, you can help some, but you're trying to find the combination of things they need to get as good as they can be. So medical research, medical treatment. So as Dr. Laitman talked about, Mount Sinai was actually the first center, I believe, I don't know about in the country, but I knew in New York they were the first one to establish a long COVID center. And now now other hospitals are kind of all opening their centers so they can start researching what's going on with it. They also have, I just put on there, we will share this presentation online after this. And again, I have a link to, New York City has a long COVID resources kind of website there. In terms of what would happen at a medical treatment, well, essentially, you're going to see a kind of a point person physician who's going to listen to your complaints and then do whatever diagnostics they need, but also refer you to the appropriate subspecialists and treatments that they think are appropriate based on your symptoms. Simply because it's like everyone, like I said before, everyone is different. So you can't just say, oh, see the COVID doctor. There's no COVID doctor. There's a doctor who can say this subspecialist, or you need to just do exercise, whatever it might be. But again, it is the first step you should do, because simply put, there's a big difference between someone who is just saying, I'm short of breath, but all your testing comes back normal, and someone who has scarring in your lungs. Because if you haven't been tested and you don't know if you truly have pathology, when you have a pathology, it does give information as to, unfortunately, if you have that, it limits your ceiling of how much better we know you can get. When you don't, it's about trying to figure out the ways to get you the best way you can. Do you guys understand what I mean by pathology? It means like, you have damage of your heart or damage of your lung or your kidneys. But it's important to understand that, because they can give medications, they can prescribe specific treatments towards those things to get you to be your most functional and your best. In terms of potential subspecialist referrals, because COVID is so vast, there are many different subspecialists they may refer to you. I'll also just mention, again, there's neurology for people who are having brain problems or issues with cognition, cardiology, people who are having issues with their heart, pulmonology, looking at their lungs, more breathing issues, nephrology, because some people are having kidney damage and issues with processing, their waste products, sleep medicine, interrupted sleep. So there are people who are looking at why you're having interrupted sleep. Gastrointestinal doctors for people who are having difficulties with digestion or diarrhea or other things that may be coming from COVID. And then psychiatry and psychology. The one thing I will say, I did know, because this was really interesting to me, was that the CDC really has urged doctors to take it seriously. Because I think some doctors are like, your tests are all fine, you're okay. And what they're finding is, it's sort of become such a huge percentage of people who are experiencing this that they're like, no, even if their tests are okay, this is a real thing. And so it's just because it's pretty much like we're trying to understand why is this happening, because it doesn't always make sense. Other things they're looking at, I figured I looked for different things because it's interesting, because you don't hear a lot about the specific things they're looking at in medicine. So I went and looked for a few things. So things they are currently trialing and researching, there's a drug called Ampligen, which is something that they've used with chronic fatigue syndrome for years. So they're doing clinical trials on that to see for people who have really severe fatigue. Because some people with long COVID, for me, I am tired virtually all the time. Okay? However, I am standing here giving a presentation after working a full day. Fantastic. I'm not doing so bad. Other people have chronic fatigue to a point where they have trouble, they get out of bed, walk a few blocks, and they're done for the day. And so those are the people who are having really severe issues. And so this is the sort of medication they may be trialing to see if it's helpful for those people. Enhanced external counter pulsation. I had no idea this thing existed. It's something they use in cardiology for people with chest pain, and it's where they stimulate your arteries in your legs to help push blood back to your heart. And they are finding for some people with fatigue and shortness of breath, it's actually been somewhat helpful in preliminary studies. And then this was an interesting one. This is one that I found that I'm like, I want to maybe check out, but it's a doctor who is the head of virology at Stanford. And he now has a company, and what he's doing is they're doing very specialized sub-testing of different biomarkers in your blood. And what they're doing is they send you a kit, you send in your blood test, they look at this, and then they talk to your primary care physician, and they say, we found this, this, and this. Maybe try these medications that are already existing, not new medications, that might be helpful for this person. So those are a few things that I found that they're doing medically in terms of trying to help long COVID. So next thing we'll talk about is acupuncture. Acupuncture has been obviously for years and years in Chinese medicine has been used to treat viral illnesses, and then there is history of it, anecdotal and published cases of people with long COVID having help, but also it's something where there is case studies and some scientific literature that supports acupuncture for use with general respiratory and viral infections. So obviously this is a form of that. And again, in terms of, like I said, there's a lot of everything we're talking here comes towards, in some people it may help a lot, for some people it may not. I certainly have known a few people who've had tremendous success with acupuncture. But it's one of those things where, it's one of the things on the list. If someone comes to me and says, I have X, Y, and Z, this is on the list of things that I may recommend they try to see what it does for them. I'm going to go very quickly through diet and sleep, because I don't think diet and sleep are necessarily causes of long COVID. However, The one thing I'll mention with diet is, remember we talked about how you can have a dysregulated biome, because COVID does cause stomach upset. I know I had long periods where my stomach was upset. I won't talk about what it did to my digestion, but it's like, and what happens with that is that also in some people it can trigger sensitivities, where your body starts becoming sensitive to things you put in your body, like foods, that it wasn't sensitive to before. For whatever reason, your body somehow becomes sensitive. It's almost like if you've heard of leaky gut syndrome, where like things get in and your body starts creating antibodies to those foods, and then suddenly every time you eat that food, you feel bloated and tired, and you get brain fog. And so it's something for people to consider if they start noticing patterns. And every time I eat this, I feel terrible. But again, it's not a cause of long COVID, but it could be a fallout of what happened during the process of having COVID. Sleep, you just need to think about making sure you're able to get good quality sleep, which may mean seeing a doctor or using different kind of herbal remedies or whatever might help you sleep better, because obviously you need to sleep to heal from a lot of this. And and then thinking about sleep hygiene, there are whole courses on sleep and how to optimize sleep. We're not going to talk about that here. We could talk about airway and apnea and all these different things, but that's just more of something for this presentation. It's not something I'm going to emphasize. Ozone therapy. So this is what I did, which helped me the most. So essentially, my symptoms were fairly severe to a point where I was not really telling everybody how severe they were, but they were really severe. This is what got me out of essentially being to the point where where existence was not super tolerable, meaning every waking minute was sort of effort for me. And so this was very helpful. It took a while. I still do it. I've been doing it for more than a year. But it was extremely helpful in getting me out of the worst of my symptoms. So what is ozone? Ozone is a gas. Now we know the ozone layer, but it's an unstable gas. It's 3 oxygen molecules. And it is actually often used in dentistry and other things for sanitization. It actually kills bacteria, viruses, fungi, but it also activates your immune system and oxygen metabolism. And it's been studied actually in medical uses for over a century. It's generally pretty safe if you're doing it properly. And again, but it can be toxic in high doses, which is why you do it under medical supervision and in a specific setting. And there are different methods of administration, meaning there are different ways you can actually do ozone therapy. The first one is intravenously. This is mostly what I have done. You take a small degree of gas, they put an IV in, and they push it in. It's pretty intense. I have legitimately, when I first did this, I would say to people, I actually feel things dying in my body. Like, it's actually a pretty intense process. Not for everybody. For me, it was extremely, the actual process is a bit intense. However, when you start feeling much better quicker, you're like, I can deal with that. Because essentially there probably was just a lot of junk built up in my system that was getting disinfected. Transdermally, so for people who can't tolerate that, because for some people that is difficult, you can do a machine called the Hocket, where you actually go into this chamber and it does it via steam, kind of gets in through your skin, and so it puts it in there. It oftentimes is less intense than doing it intravenously. Autohemotherapy is essentially where instead of them putting the IV in, they actually take your blood out, they put the ozone in, and then they put the blood back in. So that's another way you can do that. And then there's there's insufflations where you can actually do it where you can do it rectally or vaginally, which via just like a tube that goes in and kind of slowly push it in. For some people, that's something people can do. Musculoskeletally is something they do. It's not really applicable as much to long COVID, except maybe people with joint pain. Essentially with ozone, these are the ways you can administer it. Tricky parts with ozone, like with some of the other things that are not as commonly found, is there aren't super amounts of people who are doing it in terms of clinicians. A lot of the functional medicine doctors in New York do some form of it. I see someone called at the Healing Center, Dr. Howard Robbins. That's where I do my ozone. But there are, I would say relative to some other medical procedures, it is reasonably affordable. However, it's not covered by insurance. So it's something that you are going to be paying out of pocket for. Hyperbaric oxygen. Now there is some research on hyperbaric oxygen, but the sample sizes are small. So essentially what hyperbaric oxygen is essentially you enter a pressurized chamber that kind of pushes like 100% oxygen into you. Now, most of the air we breathe is not that much oxygen. It's actually not too much. And this kind of what it does is it creates the pressure to kind of push it into your system, and then suddenly you're hyperoxygenated, and oxygen helps stimulate your immune system, kind of helps clean things up and help you feel better. Also just perfuses your brain, hopefully helps you heal quicker, and hopefully you start to feel better. Again, it's been studied for many things. It's approved by the FDA for 14 different conditions. The primary thing people use it for is for wound healing. I know NYU has a center for wound healing that they use it for, but also for certain emergency medical conditions like carbon monoxide poisoning, things of that nature. Again, it's used for other off-label conditions, but that means it's not covered by insurance. So if you had chronic fatigue syndrome, some people may go for hyperbaric oxygen, but again, it's not covered by insurance. And FDA, long COVID also falls in that regard, meaning that if you see it for things that are covered by the FDA, then it will be covered by insurance, but long COVID is something you would have to pay out of pocket for. This recent study that looked at it was with a sample size of 10 patients, and they did 10 105-minute treatments. And they pretty much, the pre-post testing found improves in general cognition, in memory, I believe, in information processing and attention. Again, the limiting factor with this is, and this is something I have looked into for myself, is I found one place in the city that does it. NYU, I called them, their wound care center, they never called me back. And the other place, and they recommend kind of a more intensive course of treatment, and it's tough because it's very time consuming, because there's also a pre and a post before you get in the chamber, so the time there is actually multiple hours, and they recommend doing it many days in a row, and it also is very expensive when you add that all up. So it was a little tougher for me to do, but it does not mean it's not valid. It just means that it's going to be a little bit harder to find places to do it, but for the right person, or in other communities where maybe there are more hyperbaric chambers, or if you happen to be friends with LeBron James, because he's got his own hyperbaric chamber, then you could do that. LeBron's going to save everybody from long COVID. All right, so in terms of, manual therapy. So this is stuff that, as a physical therapist, I specialize in something called functional manual therapy, but I use hands-on things for treatment, in addition to doing exercise and other things that, you're trying to do to help promote function. And in terms of what you can do it for, you'd be surprised what it can be helpful. When I had my worst symptoms early on, actually, one of the things that was able to keep me going was manual therapy, possibly more than anything, because there were points where it was incredibly difficult to think. So in terms of what you can use it for, well, obviously joint pains. So joint pains is something that can be a fallout from long COVID. In terms of COVID joint pains, I would say this, is I have had a few where it's been like, it doesn't respond the way a normal joint would. So it's harder to say, but I would assume it's something that obviously if you have joint pains, working with manual therapy, meaning hands-on kind of manipulative therapy, would make some sense. Breathing issues, certainly not for everybody. Anything I give on this list, for the most part, there is a qualification in that it depends on why you're having your breathing issue. For somebody, for some people who were in bed for many days and their rib cage has become fixed, you're not necessarily, if they have, you can certainly do many things to help with pulmonary capacity. You can also help re-educate them how to breathe. And you can open up their spine to kind of make their lungs able to inflate more. There are things that you can do, but again, it all depends on who the person is and what's going on. And obviously, if you're talking breathing issues, you would be doing this in coordination with exercise. For the purpose of this presentation, I am separating them into separate things. Headaches and dizziness. So, I treat many headache patients. I also am certified in how to treat vestibular patients or patients with dizziness. So oftentimes you can help patients with that. I've had a few patients with dizziness. I've had with them, I've been able to get some partial resolution. But again, it's always about I don't know that I'm 100% the only person who needs to help them, because it's like you can get some of it, you can't get all of it. Again, that's with an N of 2. So meaning I don't know, maybe you can help more than I think. Dysautonomia, meaning people are having issues with their autonomic nervous system. In some cases, you can actually work on different aspects of their body that will actually impact how their nervous system is able to function. So with me, when I was having a lot of severe dysautonomia, meaning I was having orthostasis, I'd get up and almost pass out. Virtually any time I was sitting down or laying down, I would have just kind of this pressure that would build between my heart here, here, and here. And getting treated either by someone else or by myself would just take it down to a much more tolerable level. And in some cases, also with anxiety, it would also, if you started having like really big, almost like a panic attack, you could actually get that down. Again, that is not a cure. Simply put, I was helping myself manage it when things were really bad. But obviously, trying to understand why it was happening, that's the key. Chest discomfort, certainly for people who get chronic chest discomfort, there are people I've definitely been able to help who've had chest discomfort post-COVID. And that's, again, why they have it, uncertain, but again, obviously, you're clenching, you're uncomfortable for so long, it makes sense that you could develop some adhesions or restrictions that could cause that. Coughing, specific cases, I actually, just my last patient before I came here, somebody he has a history of cough and reflux, and I was treating him because after COVID, he couldn't sleep. He kept coughing, and so we had to work on actually, because of his reflux, you can treat with manual therapy things with GERD or reflux by actually mobilizing their stomach down. You can do different things to actually lengthen through here, and I also treated his vagus nerve. This is a bit more out there in terms of what people are used to, but in his case, it has been pretty successful, and in some cases, it will be. Again, I'm not saying everybody who has a cough or everyone who has GERD is going to get help with that, but it's the sort of thing for some people it will. And same thing with gastrointestinal upset, and that's also very patient-specific. Again, the types of manual therapy, these are the types of things that we do here, but also in terms of lymphatic drainage therapy, because there is a research case study on someone getting help with fatigue with doing lymph drainage manual therapy techniques. So I included that here. In terms of the things, when I talked about mobilizing stomach and different things in terms of the chest wall, like your pericardium or your pleura, which are the linings around your heart and your lungs, those are things that I was doing to myself, I was having done to me at times, and I've done with some patients. In terms of craniosacral therapy, that sometimes when there's, again, I would say craniosacral therapy is something that can be helpful in terms of calming your nervous system for people who are having severe dysautonomia or anxiety. And then lymphatic drainage techniques, I found one case study that actually talked about it reducing fatigue, so I included it here. And now on to exercise. So, last but not least. So obviously the type of exercise you're doing depends on what you have going on. For me, exercise, the first thing I did for exercise was getting out of bed. And then that gradually turned into walking. And then the first time I walked out of the house, I had to be in bed for 3 days. And then, but then you kind of gradually go from there. But I'll talk about the different exercise progressions that people are doing and how they can be effective for different people with long COVID. So for people who have more POTS-like symptoms, meaning that POTS, again, long COVID is not POTS. However, in many cases, it presents like it. And again, that's where people have the issues where their heart starts racing, they get fatigued, they get foggy and irritable, things like that when they're on their feet. So there is something called the Levine protocol, where they have looked at patients where they have the people who just have the POTS syndrome. And what they do is you start for like the first month or so, you are doing exercise, but not upright exercise. You're trying to keep as horizontal as possible. So you may be doing swimming, you may be doing rowing on a rowing machine, or a recumbent bicycle, where you're on a bicycle where you kind of can sit back and you're not as upright, as well as doing general strengthening for a month. And I think the idea is to build muscle tension, because a lot of times when you have orthostasis or the blood kind of not getting up to your head, it's because you don't have enough muscle tone to kind of push it up there. So what you're trying to do is you're trying to get your heart working, but you're also doing exercise to getting your core and your other muscles kind of increasing that tone, so when you get up on your feet, the blood doesn't drop away from your head and your heart, and you actually feel better. And again, so you start off more horizontal and general exercise, and you build towards doing things more upright, and then progressing from there. And again, with people with POTS syndrome, that has often been quite successful. And I know they are trying it now with people with long COVID, because oftentimes they present like that. So that is one thing that people may do. And that, again, that's some place you might start with somebody who has more severe issues being upright without severe fatigue, the person who can't walk 1 or 2 blocks, things like that, without really severe fatigue. Again, progressive exercise training. So this is just understanding, this is what I did with myself. which is started with getting out of bed, then walking. Then I needed to be laid up for 3 days. Okay, then I could walk this long every few days. Then it was this long, maybe a little bit longer every few days. Okay, now this long, maybe every day. And then you gradually, and then I got on my bike, and then I started riding my bike. And it's like you kind of gradually did it until you felt like you had built as much. Now, the one thing I will tell you is that I still do not feel nearly the same as I did before having COVID. I am significantly better, but I still, I rode my bike. I had a stretch where I rode my bike 2 to 5 times a week for 80 to 120 miles. And I can tell you that when I would stop for like a week and I would get back on my bike, it would feel like I hadn't been on my bike in a year. Like that's because it's just like if I didn't keep doing it, it just went away. So it was, it's not the same, but it is, you can get better. I also put a link here to pulmonarywellness.org. There's a therapist in New York, Noah Greenspan. He's a cardiopulmonary specialist. He has an interesting site where he has, I know he's doing some research on treadmill training with people who are having fatigue issues, where he's using supplemental oxygen and trying to see if that is effective. So I know he's doing that. But also, he has a site where he actually has blogs where he has different practitioners from different medical realms who come on and they talk about what they're seeing in COVID and how they're trying to treat long COVID. So it's a worthwhile site, so I kind of put it, yeah, go for it.
So are you, in this list here, are you referring to anything that's post-exertional malaise?
In terms of post-exertional malaise, I would say that could, that's an interesting question, because I think essentially post-exertional malaise is you're trying to mitigate that by what you're choosing to do. Meaning like you might choose the horizontal exercise, meaning like rowing or recumbent biking, if having somebody walk too much makes them exhausted. You might choose to do that. Or you might just say, okay, I'm gonna be very progressive and very graded with how I do it, because sometimes the reason you have post-exertional malaise is you're capable of walking 3 blocks and you're prescribed to walk 7 blocks, And that being said, I will say that, in my experience with what I've had, and that my experience is not going to be everybody's, but I can say that not all of my post-exertional malaise goes away no matter what I do. And so it's, and it's inconsistent, meaning sometimes I feel terrible after I ride my bike or something, sometimes I feel fine, and I don't always know why. Although early on it was usually I felt terrible. But I would say the post-exertional malaise is you're still trying to gradually build, because that way your heart can handle it, your body can handle it, and then you're less likely to have that kind of like, I keel over when I'm done, because your body has kind of gradually eased into that amount versus just going 0 to 60, which is, and going like really far first. So if you go more gradual, you give your body time to adapt, and theoretically you will help the post-exertional malaise. Does that make sense? Great. All right, and then core strengthening, generalized strengthening. For people who are having what we talked about, orthostasis, people who are having issues being upright without getting lightheaded or woozy, or people who are having Potts-type syndrome. Again, a lot of the way you treat that is by just building a corset, essentially, a muscular corset around you, and building muscle tone, so you can actually stop that. So it's very helpful in that regard. And then generalized deconditioning and muscle loss. Like I've changed how I work out, honestly, partially because of vanity, because I lost a lot of muscle with COVID. And so I kind of felt like for a while, I was like, I need to actually do things. I've changed a little bit how I work. I was like, I need to put muscle back on, because I was having, I like to lift my kids. And I was like sitting there like, and my kids are now, listen, my kids are 9 and 12. My 9-year-old still wants to be picked up. She's 5'1". And I like doing it, but it was getting hard, like, because I was really, really deconditioned. And so, I was part of I changed how I worked out to try to add muscle back on after I'd lost so much. Breathing exercises, obviously retraining breath. People have, even if you don't have impaired pulmonary capacity, you've become so accustomed to being short of breath. There are different things you can do. You can do exercises to open your chest, to actually mobilize and open your ribs, and then also things to just retrain how you breathe in a more effective manner. Stuff Matt's going to go over in a second, because I'm almost done. I guess I am done. Yeah, and things like that. And so there are other reasons you can talk about, do with exercise. But again, this is kind of like the extent of what we know is being done now. Have I covered everything? Probably not, because there's probably a million people trying a million things. But these are the things I've seen. These are the things I've read about. These are the things that I've experienced that have had some success. And I think right now we're all just working and trying to figure out a way to help as many people as possible, because a lot of people are experiencing these symptoms and are suffering on varying degrees. So on that, are there any questions before I turn the mic to Matt? Yes?
Yeah. Did you say something about memory?
Yes.
Loss of memory? Was it related to the post-COVID, or was it a general? I wasn't sure.
Oh, is loss of memory a post-COVID symptom? Yes, it can be.
It can be.
Yeah, Michelle is saying yes. No, I can tell you that my memory is significantly spottier. Again, it has gotten better, but it's inconsistent. I do have some issues. Certain cognitive issues for me are more difficult post-COVID. Yeah. Putting this presentation together was significantly more difficult than it was in any time I had done it before I had COVID.
The reason I ask is because I'm at that stage where I don't know if my memory is failing because I'm aging.
Yep.
Or if it's.
I was just having this conversation yesterday. The one thing I will say is it's a little bit maddening, because certainly as I've gotten better, I'm also 3 years older. I'm almost 3 years older than I was when I got COVID. And you start to question, well, is it just that I'm getting older? But there are certain things I know personally, I'm like, this was not even close to that when I was, beforehand. So that kind of tells me, okay, there's still something. For other people, it can be harder. It's harder to say, because obviously if you've had COVID and you're like, oh, my memory's getting worse, but you're getting older, and some people who are older, that might be part of aging or things of that nature. So it is harder to say. It's more, I think, if there's a sudden shift post having the infection that doesn't go away, or certainly it's just something that you're just like, it doesn't, I think it's if you're having other symptoms that seem to indicate you're having some long COVID symptoms, and that's part of it, you might be more suspicious that it's not just aging, it's part of that. But again, the truth is nobody really fully understands why it's happening at this point. So it's trying to, hopefully they will get some understanding and we can start reversing some of the things people are finding with long COVID. Yep. Go ahead.
If you've noticed anything that helps with recovery after exercise, like electrolyte replacement or anything like that?
That is a really interesting question. It's a good question. I don't know off the top of my head. There's nothing, that to me is, even with non-COVID patients, that can be a very individual thing. Some people it's like compression. Some people, I go in an ice bath. Some people it's I have to eat a certain thing or drink a certain thing. So it can be very individualized even without considering COVID. It's not something, admittedly, I've actually even thought about. I know when I was biking to and from work, partially because I didn't want to go on the train, I didn't want to get COVID again. But I know I would be very intentional sometimes about making sure I was eating, because I was like, I feel like I need it. Like I felt like I needed it, or else I was going to crash, or get worse. But again, I think that's probably a very individualized thing. But it's a good question, and it's something that maybe they will start looking at in terms of research to see if that somehow changes people's post-exercise malaise and things like that. Yep.
Well, I share my own
Sure.
experience. I just saw a doctor a couple of weeks ago who was doing a study up at Columbia Presbyterian, and after he heard my symptoms, which had to do with, like not being able to exercise like I used to, and also getting really sleepy after eating more than ever before.
Yeah.
He suggested that I try, and I was given the lean test. I don't know if you know anything about it. I think you made a reference to it where but in this case, the way he diagnosed this was like, I took my pulse, he asked me to take my pulse twice, 2 minutes, lying down.
Oh, okay, yeah, like checking for hypotension, yeah,
Yeah,
for orthostasis, yep.
standing for 10 minutes and taking my pulse every minute. Anyway.
Yep.
He suggested I take salt tablets.
Okay, yeah, no, so salt tablets,
Well, I'm taking salt
yeah.
tablets twice a day. So much more energy and stamina.
She's saying that they tested her pulse laying down, sitting, standing up. That is a test for orthostasis, meaning that with orthostasis, meaning the blood drops out of your head down there, and what happens is the more upright you get, the more gravity pushes the blood down there, and oftentimes, by actually you can do various things to counteract that. Among them are compression. So sometimes what's called an abdominal binder or putting compression stockings on your legs will help keep the blood going up, but also just increasing your salt intake can increase your blood pressure, your heart volume, so it kind of keeps pumping a little bit harder. So sometimes that can be very helpful for people. Yeah, yeah, no, absolutely. Yeah, no, great. Yep. Cool. All right, on that, I will pass the microphone to Matt McCulloch, who will go through some exercise considerations for COVID.
You can just pivot, just turn around.
Yeah. And Matt, I can adjust the PowerPoint.
You can just, yeah, just to the next slide. Okay, thank you. Just turn around. You can sit right there. I'm going to be right here.
Oh, okay.
So you can just slide over there. So this is partly, so a couple of things that I just wanted to mention quickly is, a lot of people didn't exercise, period. If we went back, didn't do anything for obvious, many different reasons. And so there were a lot of people that were just deconditioned on top of having COVID, then long COVID. So you're working from the double negative back. One of the things that we have seen in our clients is, fortunately, a integral part of the work that we do here happens to be with breathing. The breath work is already a big part of our training. We do that from the get-go anyway. And it is controlled movement. So one of the things that I've noticed with clients early on is just this understanding of truly pacing people. And people that could come for an hour normally couldn't come for an hour. Maybe it was half an hour, maybe it was 15 minutes, maybe it was 10 minutes. And it varied. It was all over the place. Where we could really be effective for them is creating a safe environment. So first of all, we deal with people that get lightheaded all the time. So we move in a controlled way. This is not, although it can be an explosive modality, it can also be very controlled. We can keep a very controlled, safe environment, and we can really modify things for people and progress them along and vary it as they're needed. So what I thought I would show, and this is going out to the layman as well as the professional as well, is just showing you how we would progress someone in just a few exercises that are very similar. And one of the things that we would start out with is always starting with just understanding where they breathe, how you can breathe. One of the things that is interesting, a lot of people that have reactive airway, we've talked if they've got long COVID, a lot of the most of us, if we are not trained, breathe very superficially and very shallow. So really high up here. A lot of individuals sit, and especially in the pandemic, we're sitting a lot. So not only the people with the best posture, we started to see more of this kyphotic posture, which is a depressed posture, depresses the rib cage. So your lung capacity, by sheer lack of activity and just lack of proper posture, is going to become very short in breath. So if you have someone that already has reactive airway, they're going to be triggered, and almost like a spasm, a coughing spasm can happen a lot. So one of the things that we would start with is just basic breathing. How to breathe deeper using your diaphragm, using not only the lower diaphragm, but posterior and 360 degrees. And one of the things that we would start with, and I'm going to show you just a progression of how we would start with someone like Elliot talked about. Maybe start with them horizontal. And you're working with them also, you have to take into account that sometimes people get lightheaded. So starting horizontal is the safe way to go. So they're here, right? And just having them breathe into a TheraBand. And often you have to really coach people through it. They start here. Then slowly but surely they're going to more of a belly breath. Then they really start to become aware of the tension of the band and start to breathe into the band. Then from here, we could progress them to a slowly but surely more of a vertical position. So you're going here. And again, continuing with this breath work. And then moving them to more of a vertical. And then progressing from just seated. Because again, everybody went from sitting infinitely more than they were. And then maybe you transition from seated to simply, remember what Elliot said, just getting out of bed for him was a major effort. So maybe it's just standing, working on breathing, that posterior breathing, and then down and sitting. And then that progresses to squats. And then from there, one of the things that we started doing is, or I've done and all of us did, a lot of people, as I said, they were deconditioned. There was less walking. No one was going out. So working on basic leg strengthening while working on the breathing. So one of the things that I found working with people with long COVID is there is a level of anxiety that may come in a realization of just where they are now physically. So often you had to take breaks, let them breathe, everything's fine, and also not overwhelming their body, not asking them to do too much coordination-wise. That also as well. So even simple things like the dizziness of the reformer, maybe that moving the carriage back and forth would cause them to be dizzy. So instead, working on their legs, we would start with them again, now focusing on the breath and focusing on just a simple leg movement here. And keeping them in more of a stationary movement versus the carriage that is moving up and down. So we're not, one of the things that we really emphasize is proprioception and coordination in Pilates and all the various movement capacities, modalities that we use here, but keeping it really simple so they can focus on two things, not a million different things. So then from here, one of the things, go ahead and click it. Changing their position, continuing to keep them mostly horizontal. So it's kind of staying in the same difficulty progression, but trying to put them in their body in different positions to where they can focus on their breath. So taking them into, for instance, a side-lying position. So having them doing some side-lying work with their feet in the leg springs and using that TheraBand as feedback. And maybe initially it's just, everyone know what an isometric contraction is, just holding the contraction. Instead of doing multiple different repetitions, just having them hold a contraction here. Focus on the breathing and then building towards repetitions. But that all can vary, again, based on that individual. If you have someone that is having heart palpitations, isometric could cause that versus repetitions. So let's say we worked on the side-lying work for a while. Then you would start to increase the load as they feel more balanced. And what all of us were trying to do in the beginning, and I've done with, and I've seen other practitioners with, we're trying to just return them to basic physical activities, right? So keeping it simple and related to everyday life, like walking, like Elliot was talking about. So in this exercise, I'm going to use this the sling here first initially just for feedback of the posterior diaphragm, just standing. And maybe this is the initial progression, having him breathe here, feeling it not only posteriorly, but also laterally. Then, and this resistance is going to get some initial core response, just standing here, because it's pulling me forward. So then maybe the next progression is simple squats. Again, emphasizing the breath. And then maybe just walking backwards and forward. I'm all right. I'm not going to go that far. And back and forward. And we can also, you can turn here. So I went from posterior in terms of emphasizing the breathing to the side, now the lateral. And just walking side. Or maybe it's just standing and having the client do some simple balancing. And the holds, again, trying to connect the breath to the movement. Same thing here. And then progressing to something a little more dynamic, like a lunge to a balance, and a lunge and balance. And really just working on just basic gait mechanics at the end of the day, but trying to connect the breath to the core and get everything connected as they recover from long COVID. So then with the chair, so if you notice, we're fast forwarding. So we did mostly kind of basic horizontal work, right? Just focusing on the breath. Then I moved to the lower extremity, connecting the breath, then the sideline. Now we did weight bearing. So now we're going to do some quadruped. So do a little more loading and proprioception. So that's where the chair can be really effective. So first, initially, it may be something as simple as, like I said, just an isometric. So just holding the pedal down, just putting all your weight in your hands and knees, and we would probably have the band on. And something that we've done is not only band around the back, but like I showed you with the sling, maybe from the side. So the instructor is holding, thank you instructor, holding it from the side, so they're breathing both from the lateral as well. Thank you. And then this could progress to just a simple push-up. So now you're going to more of a tripod, and then extending the leg back. Maybe it's a hold, and then just letting the pedal lift. So increasing the lever load and loading, but again, throughout, encouraging the emphasis of the breath. So then coordination-wise and balance-wise, after that, going from supine to standing to maybe more of a sideline position, which is going to be a little more challenging for him. So essentially, starting with some breathing here. And as Elliot mentioned, I believe, and I mentioned earlier, talking about that compression that people were getting and get after long COVID, that just from the fatigue and sitting, you get the intercostals get very tight in between the ribs. So doing any type of movement where you're opening the ribs and giving them the opportunity to breathe through there, and then progressing it from there, making it more functional and more dynamic. And then maybe eventually, once they get to a point, and again, who knows, maybe just holding an isometric here. And then maybe making it more dynamic, adding load. One variation in exercise progression that I used a fair amount is just because so many people were seated, is just the seated work in the chair. So initially, just having them and relating it again to just everyday activities, sitting at home, just initially having them sit, maybe it's supported, and just holding the pedal and tension and just focusing on the breathing. And then eventually adding the footwork, then taking off the hands for support, and then maybe increasing the pace. So you can split the pedal. And so now you've gone from more of an isometric and supported, then taking the hands away, and then maybe just some repetition. And you could play with the repetition here. You could do reciprocal movement. You could isolate one leg and do unilateral movement, changing the height. So those are, I wanted to just give a few examples of how we would progress someone over time, and that could vary, in terms of how much they could do. One of the things that I have found is that certainly some amount of movement and exercise helps to a certain degree. But as Elliot mentioned, the recovery period varies, and it can vary based on the same amount of exercise. Hydrating also is also very important. But one of the things in the work that we really do here and emphasize that I feel like overall that really helps has been just the breath work and emphasizing that in with the overall work and isolating that with the different positions. So people are breathing in a 360-degree manner, just instead of in the shallow area up around their collarbone. Do they add cardio activity to this? I have put people on the jump board on the reformer, and I've been able to intersperse in, and people have responded well to that. It's dynamic enough, but it's not overwhelming. It's not as if they're on a treadmill for a long period of time, or even going out and walking. So little spurts of that cardiovascular activity have helped. So that's just a basic summary of how and what it would look like if we progress someone from the just now and really throughout COVID, but also during with long COVID as well. Any questions? No? All right. Anybody have any questions either to Ben Laitman or Elliot? No? All right. Thank you. This video will be available at some point, but thank you for coming. I hope you enjoyed this lecture. We're hoping to do these quarterly, bring in other perspectives on various different topics. If you're interested in these types of lectures, please email the front desk any topics that you're interested in.
I have a question.
Yeah.
Do you two do different things?
Yeah.
That's not clear.
Yeah, we do. So Elliot he's a physical therapist, so generally I would say it's mostly manual work that he does. And where our two worlds intersect is Elliot, amongst all that laundry list of various things that he treats, he does work with a lot of functionality. That's the name, functional manual therapy. And then often what we do after the physical therapist treat some of the pathologies or the injuries in the biomechanics, we implement a lot of corrective exercise. So we then take the ball and continue to advance that client. And we're able to use the equipment where the physical therapists use their hands. So it's a thread it's a continuous thread that, and often what happens with a lot of our patients is, yes, they get better, but then they may take a step back and they do need some manual treatment, but they're still continuing to move forward with the corrective exercise. And it's not just corrective, we do more advanced movement than that and can be strenuous, but that is how our two worlds work together there.
Yeah, and the sort of manual exercise, movement, and hands-on work. So I'm often supervising people in doing exercises, teaching people how to exercise, but again, you can only teach people so much over the course, and it's kind of like a lot of times you have to then decide also if if there are people I refer out for people who need more like cardiovascular training or they're training for a marathon, things like that, I'm not going to do that myself. But then also if they need to like just take what we've done and build over the long term and just get better over like a 12-month period, 18-month period, then they're going to be seeing something more in the fitness world. And so Matt and the whole crew here at Kinected, they're working in terms of corrective exercise, but also exercise to kind of build strength and endurance over time, so they can take whatever they've gained in physical therapy and kind of bring it forward. Yep. Cool.
All right. Thank you.
Thank you.